very good afternoon to everybody. 我会讲华语，可是我的华语没有你们那么流利。So I'm going to present my talk today on indications and applications of neuromodulation in English. So perhaps I can get some of your comments and your questions at the end of the lecture. And if there is no time, you can always email those questions and comments to me. Now, I find that it's always very difficult to give a lecture to a group of pain specialists of varying experiences and varying expertise. Some of you are very experienced already, and some of you are perhaps just starting out. So in order to make this applicable to the wide majority, I've kept this very simple and to the point. Now, Hokkien Kyo Goyo. So I'm going to sell a little bit of Goyo right now. In April and May, in May this year, we are organizing an ASEAN Society Pain Conference in Singapore. Some of you have already submitted your abstracts. I'm in charge of all the abstracts, and I see some very good abstracts coming out from Taiwan. So I encourage you to come for this. We have very good speakers for this symposium in Singapore. Severo, the president of the IASP, Richard Ricardo from Barcelona, the president of WIP are all speakers in this event. I'm also on the scientific committee of the 2014 World Congress of Pain by WIP in Maastricht in Netherlands. Also in May, but in the following year, we have a very, very exciting schedule. I just came back 2 weeks ago from Amsterdam. We planned a very exciting scientific program. So do block your calendars and come for this in Maastricht. Maastricht is a very, very old city in Holland, and it's a very beautiful place to visit. And it's a good time of the year in May. It's warm and it's not freezing as usual. Now, so as we've all, I have to do a bit of disclosure first. I've received honorarium and travel expenses from the following companies, okay, just to get that out of the way. And we go straight into the scope of my lecture today. Now, I'm not going to spend an hour or two just speaking about the background and mechanism of actions, but it's important to understand. It's important to understand why chronic pain is a big thing and why neuromodulation or spinal cord stimulation is so important. So now, the background, we have to see how big the problem is. Now, looking at all the, I trained in Europe, so I'm giving you some European data. In Denmark, a general population of 38% of them suffer from some form of chronic pain at one point or another. In Sweden, up to 45%. In Netherlands, the total cost of conviction alone on neck pain was estimated to be about $686 million. And in the United Kingdom, if you look at just the cost of lower back pain to the direct healthcare structure, it's 1.6 billion pounds. But if you consider the indirect costs from informal care, loss of work, it's up to 10.7 billion pounds. So where does neuromodulation stand in our entire continuum of care? Now, right now it's here. Okay? But we are moving it forwards more and more. Why? Because it may be able to avoid further surgery. If you compare Kumar and North actually did pretty good work on that. If you compare the cost of repeated spine surgery to neuromodulation, we end up cost saving in the end, which I'm going to go into a little bit more detail later. So, the mechanism of action of spinal cord stimulation in the past, we thought was entirely just due to this. This was all the way back in 1967, when Shiley first started doing, accidentally found out that spinal cord stimulation, electrical stimulation, is actually able to inhibit pain. We all thought that it was because of the interneurons that, from the gate theory. But today more and more work has been done. And two dominant mechanisms stand out. The first is the antidromic activation of segmental inhibitory circuitry. in many words, it just means an expansion of the gate theory. On top of just the interneurons, now we know that glutamate, GABA, and a lot of inhibitory neurotransmitters are stimulated and released. And that's one of the major mechanisms. But the other interesting mechanism that we know of today is actually an autodromic activation of circuitry in the brainstem. Now, this results not only in spinal cord stimulation results not only in segmental effects, but rather it stimulates a descending inhibition. We know that your brain, from your brainstem, there is actually parts of it that from periaqueductal gray, RAP, they are able to secrete neurotransmitters that come down and control your pain. And so that's what it means. And there was a very interesting study done by Song in 2009 that was an animal study, but they compared the amount of serotonin in sections from L4 and L5 taken from the ipsilateral and the contralateral horns of the spinal cord after spinal cord stimulation and without spinal cord stimulation. And they found that the amount of serotonin levels differed. Okay? Right? You can see the amount of serotonin levels actually differed. So now this is only on serotonin. We all know that actually the predominant neurotransmitter is actually noradrenaline. There are some studies that have been done, but it's not conclusive at the moment. But this study was very, very interesting to me. Now, neuromodulation. The reason why I chose the topic indication and applications is because when you first start doing spinal cord stimulation, it's very important to choose the right patients. And it's very important to choose the kind of patients that are approved for spinal cord stimulation. And that's why the two words, indications and applications. Indications, I will go into a little bit more. Now, these are all the different kinds of conditions that neuromodulation has been used to treat. It looks like it's like a holy grail of everything, but it's not true. Okay, it's not true. We're going to go into each and every into some of them, not every one of them, especially those on top. Those below, some of them are not my field. Now, I took this from all the different major companies' websites. These are all indications stated on Medtronic, St. Jude's, Boston Scientific. Now there's a Nevro as well. So there are very different, many companies that are doing spinal cord stimulation, some being touting one better than the other. But these are all the indications that are from their websites. I'll condense it a little bit better for you. And we'll look at each one separately. Now, the ones in red are currently accepted indications in the US. Field back surgery, arachnoiditis, which is a subset of maybe field back surgery, and CRPS, complex regional pain syndrome. Now, those in blue used to be indications, but because of negative reports in some papers, now some of them have fallen off the indication list. But they are still very good. Well, I do a lot of them, so I actually find pretty good results, especially in refractory angina. Now, the ones in green, unfortunately, are still considered off-label use. Well, even though there are known cases or known indications of peripheral neuropathic pain, unfortunately, it should still be done under study settings. So, we're going to go first into the real solid indications. We'll talk a little bit more about the ones in blue, and then we'll talk about the studies that have been done for peripheral neuropathies as well as the weaker indications. Now, why does spinal cord stimulation work for so many different conditions? It's because of this. Here. All these organ responses happens when you stimulate the spinal cord. Bronchodilation, vasodilation, you have decreased infarct size when you stimulate the T1 and T2 spinal cord. Now, applications are when it is not a solid reason to do spinal cord stimulation. You don't have enough studies, you don't have enough evidence to do it. But it is not stopping us from offering this to the patient. The patient needs to know that the company doesn't say this is one of the recommended indications, but results from the literature supports it. So this is what I coin applications. And you can see there's actually a lot. Even if you look at case reports in the literature, you will find that in Lancet just 2 years ago, there was a paper that was published on spinal cord stimulation in a patient with spinal cord injury. And after 26 months, the person started to walk again. So it's a growing field. Now, but I'm going to go straight into the first most important indication, unfortunately also the most difficult indication, and that's failed back surgery syndrome. Now, 200,000 patients in the US undergo spine surgery a year. 20 to 40% of these patients fail to gain the desired outcome. And of this, 10%, up to 10% will be worse after the initial surgery. Now, these numbers are astounding if you look at it by itself. And what we sometimes I don't like to use this word failed back surgery syndrome. I tend to use post-laminectomy syndrome a little bit better because the neurosurgeons and the orthopedic surgeons are my friends, so it's not nice to call something failed. But the reality is that the definition of failed back surgery syndrome is actually a clinical outcome, simply a clinical outcome whereby back or leg pain recurs or persists after what seems to be a successful surgery. Now, Richard North in 2007 actually published this, and I thought it was quite illuminating to see the amount of what neurostimulation could do compared to reoperation. We know, the surgeons here will tell you that reoperations comes with its cost. It's not an easy operation to operate at the same site. The anatomy is different, the scarring is different, bleeding happens more. So there's a lot of problems not only with reoperation in terms of success, but technical difficulties as well. Arachnoiditis is also an approved indication in the US. It's not only because of surgery that you get arachnoiditis. Now, these are known causes. Infection is one of the main causes. Now, in the US and in some parts of the world, hypertonic saline is used to treat scarring in the back. But hypertonic saline is an irritant, and in some subsets of patients, it can also cause arachnoiditis. Now, we go into the next common indication for failed back surgery, for spinal cord stimulation, and that's CRPS. Now, as anesthetists, we used to call this condition RSD, reflex sympathetic dystrophy, or Koselja. Now, the IASP had coined this definition many years ago. Koselja is really when there's a nerve that's involved, and CRPS type 1 or RSD is when there is no documented nerve injury. The mechanism is still up in the clouds. Nobody really knows why CRPS happens. We believe that initially it's a peripheral mechanism, but later on it becomes central, as with many neuropathic pain. But it's a very interesting condition. And this one has just been published. It's a review paper by Pori that states that spinal cord stimulation should not be left as a last resort. Why? Because you know that in CRPS, you end up seeing the dystrophic and the atrophic stages, or the dystrophic and the atrophic types of disease. And when you get to the atrophic stage, you're not going to get back the mobility. You're going to end up with contractions. You're going to end up with a lot of muscle wasting. So it should not be left as a last resort. Now, staging of CRPS, we all know this, but it's not very clinically very relevant. We do a lot of stellate ganglions. We rehabilitate the patients very early, remove the joints, and because of that, we find that we actually end up doing less and less spinal cord stimulation because once you actually get the joints to move, the pain resolves quicker. Now, I'm big on pain diagnostics. My PhD is on QST. So I use a lot of QST to diagnose neuropathic pain. And now you know that in CRPS, you sometimes see the very inflamed peripheral limb. and there's a lot of sympathetic overactivity. But sympathetic overactivity or a swollen limb is not diagnostic of CRPS. It's not. There is sympathetic independent pain. There is sympathetic independent CRPS. And you have to recognize that, because it doesn't mean the arm is not swollen, it means it's not CRPS. So just a few pictures to wake you up from your afternoon lunchtime talk, because this is a bad time to be giving a lecture. Now, so if you look, this is very early. Not everybody has this. Not everybody has this. But when you see this, it should run through your mind. I'm dealing with a soft tissue injury. There may not be any bony involvement. Sometimes they end up with a dystrophic stage. Sometimes. Many patients skip this stage. Many patients skip this stage. Many patients go from this stage to this. When there's a lot of wasting, deformity of the limbs, and that's too late. You don't want to be doing spinal cord stimulation at this stage. You can control the pain, but you're not going to get the patient back his limb. So, story time. Now, this is a patient with CRPS, and she had it for 2 years. Now, interestingly, this patient had sympathetic independent pain. We did the static ganglion. Pain went away for a good 6 months. Came back. She's a restaurant owner. She cooks. She does everything. She was very, very active until she had this problem. So we put in the spinal cord stimulation. We did a trial for 1 week, and finally we inserted at this level. Today, she's back in her restaurant. She owns 2 restaurants now, and she's doing really, really well. So again, now for some of these motivated patients, this might be an option that we should do earlier. She's still using the spinal cord stimulator about 3 or 4 times a day, not constant, but this is a very good case study that we shouldn't leave it as a last resort, because when your arm gets wasted, it's too late for the patient. So we inserted this top lead almost to about C3, and we use the subcompact. The subcompact lead. The neck, the spaces are a little smaller, so we need to use the subcompact leads. Now, the other interesting indication, well, I would say it's an application. I was following out of the insurance coverage for spinal cord stimulation. So, refractory angina pectoris. We all think that spinal cord stimulation is only able to do nociceptive pain control. Gate theory. This all comes from gate theory. We think that it's only able to do that, but actually not. No, spinal cord stimulation does more than that. I told you it stimulates the local neurotransmitters. It also stimulates descending neurotransmitters. On top of that, for refractory angina pectoris, there's many both bench work and animal studies and human studies that have been done to show that it actually increases blood flow, decreases ischemia. Interestingly, we're now doing a study on cardiac failure. And it's also cytoprotective. So a lot of the local segmental neurotransmitters are able to do this, cytoprotective effects. And on top of it, it's something akin to ischemic preconditioning. Ischemic preconditioning. So all these are the postulated or proposed mechanisms that it helps in refractory angina pectoris. And you know that in refractory angina pectoris, the patient may have already undergone several stenting. So all the larger vessels in the heart has already been stented, and local blood flow has increased. But the smaller blood vessels, which is some that you really can't stent, are perhaps one of the pathophysiological mechanisms of refractory angina pectoris. So, Peter Mannheimer, all the way back in 1988, already knew that it's very efficacious for this group of patients. It's already known, this is a known fact, but there was a couple of years ago, there was a recent negative report that came out of this, so that's why they took it out as an indication. Now, Youngster in cardiology 1994 did another study that showed not only did the incidence of angina attacks were reduced with spinal cord stimulation in RAP, the amount of usage of nitrates actually went down as well. So if that was only pain control, then this wouldn't be evident. right? So there is an increase in blood flow, there is reduced ischemia, and there is effects more than just nociceptive control. So we know what causes angina, we know the risk factors for angina, and these number of patients, the number of patients that are not candidates for revascularization is increasing more and more. So one of the questions I'm always asked by my cardiologist colleagues, as well as my pain colleagues, is that, will spinal cord stimulation actually conceal or mask the pain of an impending myocardial infarction? The answer was actually provided by Anderson all the way in 1994 already. He did a prospective study of 37 months, and he found that 10 out of the 50 patients actually experienced myocardial infarction. And 9 out of these 10, even though they had SCS on, they were able to clearly and correctly differentiate the pain of a typical angina attack than that of impending MI. So the patients are able to tell there is a difference. So the answer to this question is no, it will not mask it. Okay? The next very good indication is ischemic pain. Unfortunately, in my country, a lot of patients cannot afford, a lot of patients with ischemic pain will not be able to afford spinal cord stimulation. So I put in very few spinal cord stimulators for ischemic pain, but it's a fantastic indication. Now, peripheral vascular disease, the contributing factors, we all know it again. And now in 1995, JPR actually did a randomized study of 51 patients with critical limb ischemia, means the foot is, they're losing the foot. He randomized them into two groups, one on oral medications and the other one with spinal cord stimulation and oral medications as well. He found that there was actually very significant improvement in pain scores in the group treated with spinal cord stimulation. Not only in terms of pain, but also in quality of life, as well as perfusion to the foot. Interestingly, now, remember the ischemic pathway I talked about? It is the same thing that is happening in peripheral limb ischemia as in refractory angina pectoris. Same mechanism. A Cochrane review done just 5-6 years ago looked at 6 studies comparing SCS versus conservative treatment. They actually saw that limb salvage was significantly higher than in SCS group. Limb salvage, meaning the ability to avoid an amputation. That to me was pretty remarkable. Now, we talked about mechanisms just now. Now I put inhibition of nociception as a small print because in ischemic pain, the major mechanism is not inhibition of nociception. It's actually the epidromic vasodilation, the reactive of transmitters that results in vasodilation, and the modulation of autonomic activity. So this results in the decrease of oxygen-dependent metabolism in the ischemic limb. That is probably why the Cochrane review found that the spinal cord stimulator group was able to have higher rates of limb salvage. So, in summary for this slide, spinal cord stimulation seems to act primarily on tissue ischemia and not on pain itself. Now, we need to talk about a bit of applications. Now, if you are going to start spinal cord stimulation, I would suggest that you choose your patients very strictly according to the first few slides that we talked about. Those are good patients to start with. Now, these are good patients too, but unfortunately, they are not exactly an approved indication at the moment. Post-herpetic neuralgia, phantom limb pain, painful diabetic neuropathy, well, I believe this is a very good indication. But again, you have to choose your patient very wisely. Multiple sclerosis, and even spinal cord injury. We need to talk a little bit of diabetic neuropathy. The evidence is growing, it's getting stronger and stronger. The Noman and group actually just published a pilot study on painful diabetic neuropathy, and it's actually a very good indication for spinal cord stimulation. Now, painful peripheral neuropathy does not equate to diabetic neuropathy. It is a subset. Diabetic neuropathy is a subset of painful peripheral neuropathy. It's actually a variety of conditions, and in general falls into three categories: metabolic, drugs, as well as idiopathic. So metabolic and diabetic neuropathy will fall into this category longitudinally. So how far to put it in? Now, if you look at the anatomy of the skin, you realize that you can't put it too far in on top of the muscle fascia because it will cause a lot of pain. You can't put it too superficial because you're going to stimulate a lot of the free ending C fibers, and that's going to cause a lot of burning pain. So the optimal depth is really in the subcutaneous tissue, above the muscle fascia but below the dermis. So you don't want to catch the free enough endings that it's going to cause a lot of C fiber activation and burning pain. Now I'm going to flash the next few slides because it's getting late, but this I can't leave you without telling you of some of the exciting things that are happening. We are putting in paddle electrodes, small paddle electrodes percutaneously using this thing called an epiducer. This is from St. Jude's. Well, it's postulated that there's less lead migration with a paddle lead. MRI safe leads, a lot of shielding has gone into this device, such that now the RF protection from MRI this lead can actually undergo that without heating up. High frequency spinal cord stimulation. Now, conventional versus high frequency versus burst stimulation. The verdict is not out yet. The problem about high frequency stimulation is that we can't feel it. The patient can't feel it. You don't get paresthesia. So your traditional idea about coverage and paresthesia covering your painful area is gone. So people don't know whether it's going to work or not. But it's one thing it allows us to do is to do an actual proper blinded trial. Put in a patient, high frequency stimulation versus no frequency versus no stimulation. Patient won't know actually. But again, jury is not out yet. In one center in UK, they do it at 10,000 kilohertz. Most places start at 5. So again, we don't know. Burst stimulation, also very promising. The animal studies actually show that burst stimulation is actually a lot more effective in stimulating the autodromic descending inhibition. So again, I leave this to your reading. This is the reference, the reader, and he's found that burst stimulation may be the next wave of the future. Dorsal root ganglion stimulation, I think you heard something about it this morning. I haven't done anything like this at the moment, but I think if you find a patient with only a specific radicular symptoms, this is not a bad idea. Medial branch stimulation, this is something new again. Now they've developed leads that are able to hook onto the set joints of the medial branch, and this is a CT reconstructed view of what it actually looks like. And this is the X-ray picture of what medial branch medial branch stimulation actually does. Again, just to remind you of the conference coming up in May in this year, as well as the one coming up in May next year. Thank you very much for your attention.